client is Mr. Joseph Pine. He's 56 years old and owning a restaurant. He was diagnosed with diabetes mellitus 5 years ago and also has obesity. He doesn't do much exercise, just sometimes walk to the train station, which is 5 minutes away from his house. He's now living with his wife and son. He doesn't smoke and rarely drinks, but his mother died of complications of diabetes, which was a heart attack. He's prescribed with metformin now. Normally, insulin synthesis happens in beta cells in the pancreas. These cells are the only cells responsible for producing insulin. When blood glucose level increase, they secrete insulin to lower it. Glucose transporter unit, also called GLUT, move glucose from bloodstream into cells. Two-thirds of body cells need insulin for this process. Insulin will then bind to the receptors in cell membrane, trigger GLUT to move glucose from bloodstream into cells and lower blood sugar level. In Joseph, however, these processes are going wrong. The first problem is that when insulin binds to receptor, they either couldn't recognize insulin or may have a problem in sending messages to the GLUT. So, GLUT cannot pick up glucose and his blood sugar level is still high. His beta cell then have to make more insulin and release more insulin to cope with that, but thalamic cells are still starving up glucose. Joseph is now at risk of suffering many complications, especially if hyperglycemia is poorly controlled, and some of them are retinopathy and angina pectoris. Firstly, about retinopathy. More than 60% of patients with type 2 diabetes are expected to develop some form of retinopathy by the first decade of the incidence. A recent study has confirmed that two major risk factors of retinopathy are hypoglycemia and hypertension. Firstly, if Joseph cannot control his blood glucose level well, he may get hyperglycemic. Moreover, as a result of combination of diabetes, obesity, and inactive lifestyle, he may also get hypertension, which is another major risk. So, he is at risk of developing retinopathy. Another problem is angina pectoris. Patients with diabetes have a 2 to 4-fold greater risk of developing cardiovascular disease than non-diabetic patients. Angina starts with an atheroma in coronary arteries. Glucose together with amino acids create some glitter complexes that can attach and damage endothelial layer. They also attract more LDL to the site, so the more glucose Joseph has in bloodstream, the more chances got to have an atheroma. Moreover, as mentioned before, Joseph has an inactive lifestyle, obesity, and high risk of hypertension, which are all risk factors of atherosclerosis and also angina. Thus, angina pectoris is another problem Joseph needs to think of. As for medication, Joseph is now having metformin. His beta cells are still fine and he has sufficient insulin. The problem is that his cells cannot respond to insulin. Metformin acts by reducing hepatic glucose production and increase glucose uptake and utilization by muscle cells, which can prevent hyperglycemia. Metformin can increase insulin sensitivity, and it also reduces LDL level, which reduces the risk of developing atherosclerosis and other cardiovascular diseases. Interestingly, metformin doesn't pose any risk of developing hypoglycemia and weight loss like other oral hypoglycemia drugs. Abdominal fat plays an important role in causing insulin resistance. At the same BMI, the more upper body fat has been found to be associated with a higher risk of type 2 diabetes compared with the less. The mechanism of this is that abdominal fats produce free fatty acids, and these acids are absorbed to the hepatic portal vein and go to the liver. The more abdominal fats we got, the more fatty acids are delivered to the liver. It says lipid accumulation in liver disturbs cells mechanism involving insulin signaling. This also induces inflammation, also causes release of inflammatory cytokines which impair insulin actions. Glycosylated hemoglobin test is a good indicator of long-term blood glucose level. Glucose can bind to hemoglobin irreversibly. The more glucose in blood, the more attached to hemoglobin. And lifespan of red blood cells is from 2 to 3 months, so the test can indicate blood glucose level over 2 to 3 months. This measure is useful for Joseph because it indicates blood glucose level over a long period of time rather than just a random point of time. Thus, this is more precise and useful in monitoring progression of the disease. Secondly, it's convenient as it requires no fasting and strict diet before the test, and only one blood sample is needed rather than 3 like the oral glucose test.